maternal deaths of 58,000, which mostly occur in the rural areas. This is according to the World Health Organization. With such a gloomy picture that we have, you would agree with me that such an intervention project cannot occur at a better time than now. And with a lot of efforts and interventions currently going on by the national government of Nigeria and the state governments, including the development partners operating in Nigeria, it is our earnest expectation that the results of this study will translate to policy decisions that would help us to improve quality of services rendered at our primary healthcare centers. This research was conducted by the Women's Health and Action Research Center, WHARC, in Edo State, Nigeria, a non-governmental organization in collaboration with University of Ottawa, Canada, and the Ministry of Health. The research is part of the Innovating for Maternal and Child Health in Africa, IMCHA initiative, jointly funded by the Global Affairs Canada, the Canadian Institute for Health Research and International Development Research Center, IGRC, and the webinar is co-hosted with the West African Health Organization, which is providing support for the IMCHA research team in the region. Distinguished participants, we are here for a rewarding time to listen and to learn from the team who were directly and indirectly involved in this research work. We would have opportunity to watch such short clips of videos of participants or beneficiaries from the various communities in Edo State who would share their experiences with us. And we will have time for comments and questions to be able to accommodate opinions about this. On this note, distinguished participants, I want to welcome you again as we listen, and we'll move on to the agenda directly. So given that, we'll welcome the Chairperson, Board of Trustees, Professor Agatha Iguavon, to give us a welcome address. Thank you.
So I'll share the screen. Okay. Good afternoon, everyone, and welcome to this presentation. It is with great pleasure that I, on behalf of Women's Health and Action Center, welcome you all to this presentation of our research findings on optimizing primary care for skilled maternal health care in rural Nigeria. Rural communities in most countries are neglected. Nigeria is not an exception, where attention is focused mainly on urban centers. This work is a research/intervention study carried out by WHARC on the leadership, under the leadership of our dynamic professor and leader, Professor F. Friday Okonofor. WHARC is one of the Nigeria's leading NGOs, which has grown over the years in handling women issues in general and reproductive health issues and concerns in particular. And so WHARC has become a very source of pride to all of us in this country, Nigeria, and the women folk in particular. We welcome all our collaborators in this study. We are grateful for your participation and input. We are grateful for your support, as we are here today to receive the outcome of a 4-year study which has been going on trying to interrogates how to increase or improve on maternal mortality, not only in Nigeria, but in all other countries of the world where high maternal mortality is an issue. As you all are aware, Nigeria is the second highest in the world, followed just after India. So the choice of Nigeria as the study area, is quite informative. The presentation we're about to give now, we encourage all to listen attentively and to note carefully it's an evidence-based intervention into the maternal mortality in the country. And as such, we want to encourage that it's not enough to listen, but kindly request that we make it a policy issue in the recommendations that we follow, or from the Nigeria in particular, our position is very unenviable. We occupy the unenviable position of being the second best in maternal mortality. This study, which started about 4 years ago, and today we are giving you the outcome. It's my wish and desire that it forms a policy framework in this country and other countries. I'm hereby encouraging all to listen and take into consideration very seriously the outcome of the study. As we receive this report, I welcome you all to this webinar, and I wish you a very, very interesting webinar discussion. Thank you and welcome to the presentation.
Thank you, Professor Agatha, for that welcome remarks. And just like she has said, we are here for a good time to listen to this report, and most of us will be able to take one or two things home, learn from the experience shared on this report. I recognize the presence of Dr. Olusegun Mimiko, the former governor of Ondo State and the originator of the BA program, another maternal and child health intervention program in Ondo State, acclaimed and world-renowned program. Welcome, sir. Moving to the next item on the agenda, we welcome Dr. Sana Nafa to give us a presentation on the overview of the IMCHA project and our goodwill message. Dr. Sana, please. Thank you.
Good morning, everyone. I hope you can hear me well. Good morning, everyone. I'm so glad to be a part of this interesting webinar. It's so impressive to see all the people from the research team in Nigeria and from West Africa region, West Africa Health Organization, very distinguished guests, all joining us today in this important webinar. This interesting project is one of the 28 research projects under IMCHA initiative. IMCHA is the Innovating for Maternal and Child Health in Africa initiative, which is funded by Global Affairs Canada, this Canadian Institute for Health Research, and International Development Research Center. It's a partnership between different partners between Canada and Africa. The initiative started in 2014, and the purpose of the initiative is to improve maternal, newborn, and child health outcomes in Africa by strengthening the health system using primary health care as an entry point. The specific objectives of the initiative is to address the critical knowledge gaps and increase awareness among policy decision makers about affordable, feasible, and scalable primary healthcare interventions, and to build the individual and institutional capacity for gender-sensitive health systems and solution-oriented, and enhance the uptake of relevant research to inform policy and practice, as well to strengthen collaboration between Canadian and African researchers working in partnership with decision makers to implement and scale up quality services to improve the maternal and child health outcomes. The initiative started in 2014, and it will end in July 2021. And the total amount of funding is around 36 million Canadian dollar. And it included 28 research projects, 9 originals, and then in the midway, another 9 synergy grants were added. 2 health policy research organizations, one in West Africa Health Organization, and a consortium in East Africa. The countries included are Burkina Faso, Ethiopia, Kenya, Malawi, Mali, Mozambique, Nigeria, Senegal, South Sudan, Tanzania, and Uganda. This shows the distribution of the 19 original grants and the 9 synergy grants, and the location of West Africa Health Policy Research Organization, West Africa Health Organization, as the health policy research organization for the West Africa region, and the East Africa Health Policy Research Organization, a consortium of the African Population and Health Research Center, the Partnership for Development in Uganda, and the East and South Africa Health Community Health Committee, which is also a partnership between the 3 consortiums. The distribution of the 28 research grants were designed by thematic areas, and these thematic areas are facility-based interventions, community-based interventions, policy enabling environment interventions, and the human resource for health interventions. And the synergy grants were added to address areas like adolescence, reproductive health, family planning interventions with a more gender transformative and deep thinking of qualitative data to support the research objectives. However, these research did address more than one thematic areas. For example, the one facility-based intervention in Tanzania was to improve the problem-solving quality improvement cycle at the facility level, and they included the communities and the district level organization and operation. So they started all 3 levels to implement the quality improvement cycle within their work. Another example of community-based intervention in Nigeria is the universal health, the universal home visits in Bauchi state, and they addressed the community level. At the same level, they did policy interventions which led to institutionalization and building a unit for home visits at the state level. Also, the human resource for health, one example from Tanzania is that they built the mid-level managers' capacities, and at the same time, they scaled up their intervention to embed and endorse the curriculum for comprehensive emergency, neonatal, and obstetric care at the state level and at the national level. I will not go more in details. I look forward for these presentations and to learn more about your success and your accomplishments. And we will have also part to discuss if you have questions and to have dialogue about the IMCHA initiative and the implementation of this ambitious, important initiative in Africa. And thank you all for listening. Thank you. Over.
Thank you, Dr. Sana, for that brief remarks and the overview of the IMCHA project in African region. Just like we have heard, Nigeria is one of the beneficiaries of this project within the region. And within Nigeria, we have project sites like the one going on in Bauchi State, in Oyo State, and here in Edo State. We hope to listen to the outcomes of this particular research in Edo State, and we'll see what lessons can be learned from it and how we can scale up from this. Well, thank you once again, Dr. Sana, for this overview. While we wait for Professor Stanley Okolo to listen to his own remark and to see what policy WAU has in line with these thematic areas. Is Professor Okolo ready for us, please? Okay. By the way, Professor Okolo is the Director General of the West Africa Health Organization. And I don't think he's here with us yet. While we wait for him, to save time, let's go on to the next presenter. Dr. Wilson Imoagon is the Executive Director of the Women's Health and Action Research Center here in Benin City, and the former Commissioner of Health in Edo State. Is familiar with terrains, and he understands the issues, what the issues are here in Edo State, and he'll be able to enlighten us. Is a major part of this research, and he will be able to shed more light for us on this. Dr. Imoagon, please. You're welcome. You're welcome.
The Women's Health and Action Research Center carried out a project, the project titled Increasing Women's Access to Skilled Pregnancy Care in Rural Nigeria. This program was informed by the fact that Nigeria has one of the highest maternal mortality rates in the world. The country's estimated annual over 58,000 maternal deaths accounts for 19% of the global total. And a major reason for this is because most of our rural women in Nigeria do not attend primary health care centers for maternal health care, that is, antenatal care, postnatal care, and even giving birth. Meanwhile, Nigeria government has made maternal and child health a priority, and the fact that we have over 30,000 primary health care centers in Nigeria to address this priority. Meanwhile, in Nigeria, the Nigerian government has it that primary health care is the entry point to health service delivery. And indeed, pursuant to the above, the government launched a plan in 2017 to revitalize over 10,000 health centers across the rural areas. Our research was designed to generate empirical data to support this revitalization effort of the Federal Ministry of Health with evidence-based recommendations. Therefore, our project goal was to increase rural women access to skilled pregnancy care, because we understand that in Nigeria, less than 50% of women have skilled pregnancy care when pregnant or when giving birth. The specific objectives include: one, the overall objective is to reduce maternal and perinatal mortality in Nigeria by strengthening the availability and use of primary health care for maternal health services by vulnerable women. And two, to explore why women use or do not use primary health care centers for maternal health care in two local government areas. These two local government areas are located in the rural areas. Three, to implement a series of multifaceted interventions for improving the demand and use of primary health care centers for skilled pregnancy care in the local government areas, and to test the effectiveness of these interventions in improving women's use of evidence-based primary health care for maternal health services by comparing maternal and child health outcome indicators before and after the interventions. The project was in two phases. First, there was a formative research that generated the baseline and then the intervention phase. Today, we will report on the project, the results and achievements of the interventions at this dissemination. Thank you for your attention.
Thank you, Dr. Wilson Imogan, for that brief introduction into the work done as we read into more of the work done. I don't know if Prof is with us now, the DG of the West Africa Health Organization, Professor Kolo. While we wait for him, I want to recognize the presence of the king of Okpekpe community in Edo State, one of the communities, beneficiary communities, where this project took place. Now I can cite Professor Kolo. You're welcome, sir. Professor Kolo is a gynecologist, obstetrician and gynecologist, and currently the Director General of WHARC. So you would agree with me that he understands what the issues are and is passionate about taking care of women and children. And I'm sure one of his major objectives as a Nigerian and as the head of this health organization within the ECOWAS community is to ensure that we have better services delivered at our rural areas so that we can save the life of more women, pregnant women in such communities. We welcome you, sir, Professor Stanley Okolo, for your remarks and the policy implication for WAO of this. Thank you, sir.
Thank you very much, Toshiya. It's good to see all of you. Good afternoon, Your Royal Highness. Good afternoon, Professor Konofua. Good afternoon, ladies and gentlemen, researchers, active people. I am really delighted to join you, and apologies that I cannot be with you for the full 2 hours because of a clash of responsibilities and scheduling. I'm extremely pleased that the doyen, as we know him, Professor Konofua, and WHARC are continuing to blaze the trail regarding the issues of how to improve maternal health, women dying in pregnancy and childbirth. We all know what the major problems are, and the delays, classified often as 4 delays and sometimes up to 5 delays. We are all very grateful to the Canadian government and the Canadian people for helping us in terms of this project. We understand that the project is predicated on looking at 3 different areas: individual level, organizational, and institution, in terms of what we can do to improve the fact of women dying in childbirth. What I want to share with you for the next 5 minutes, maybe up to 10 minutes, is really on 2 or 3 things. The results of the research will be disseminated. You will see the results, and I'm not going to go into that. But I really want us to think about 2 or 3 things. One is, so what does it mean for me? When I look at the participants of this meeting, there are 139 people on this webinar, 140, including myself. When I think of the people I have seen in the list, there are policymakers here, people from directors in the Federal Ministry of Health, and I expect people from state ministries of health. What does it mean for me? That's the first question I'd like us to share and think about. The second question is, how scalable is this? How can we scale it to not only other countries? We have responsibility at WAHO for 15 countries in terms of bringing best practice to other countries. How can we scale this up? And the third, which is why I'm really delighted that we have religious and community leaders with us at this webinar, is how do we sustain it? What makes it sustainable? When this administration started in WAHO 2.5 years ago, one of the things that we tried to do was to streamline our focus and our energy into 5 themes. We had about 13 priority projects previously, but we felt we can actually have only 5 priority themes. And these priority themes have some enablers, and I will share that with you. One is maternal health, child health, and adolescent health. And we make no apologies about that because we know that it is a critical issue for us in the region. A high cost of maternal death. As I'm sure you are aware, communicable diseases and maternal health, or deaths in pregnancy and childbirth, account for over 55% of deaths every year in most of our countries, of our 15 countries. So that's why we put maternal health, child health, and adolescent health as one of our 5 themes. The second theme, of course, is prevention of communicable and non-communicable diseases. And today we are battling the COVID-19 pandemic. We have had continuing outbreaks. Even during this year that we have the pandemic that is global, in West Africa, we have had 5 or 6 different outbreaks in different countries. In Nigeria, you know that there is a yellow fever outbreak at the moment, which is ravaging and killing people in some of those camps. So those are some of the things that we have within the prevention of communicable and non-communicable diseases. The third theme we have is the theme of drugs and vaccines. How do we ensure that we reduce the over 60% of drugs that we use that we have to import? And because we import it, the regulation and the quality control is very poor, and the borders are porous. And because of that, we have nearly 10 to 20% in the market of false drugs. I have been a victim of that. Now, that's because I had pain and I bought some drugs and I was using it and it didn't cure my pain. What of people who have hypertension and diabetes, who would not know, and they are taking medicines that are falsified, and then the next thing they have a stroke? The fourth area that we really have decided that is one of our major themes is the issue of quality standards and centers of excellence. And for this webinar being organized by Benin, we regard Benin as a center of excellence in terms of the research that is coming out of it, in terms of the trail that they're blazing regarding how to reduce the issue of maternal mortality. And the final theme of our fifth theme is health information. How do we promote the information we get? How do we also ensure that in West Africa, we have specific information for our population? And that is where this webinar today becomes extremely important. And that's why WAHO is supporting it and supporting it strongly. I feel that if we can tackle these themes with the enabling factors, which is number one, how do we build capacity? One of the things that came out of this research is the need for skilled birth attendants in terms of reducing mortality. So how do we build capacity? That is really important. And all our projects that we support, we have to look with an eye for how does it build capacity. The second is how do we strengthen the network across West Africa? What can we learn from this research that we can then apply in Sierra Leone, in Liberia, in Niger, in Mali? Because disease knows no boundaries. It's the same women who are giving childbirth in Benin that are giving childbirth in Katsina. We need to make sure that therefore it's scalable. And the third enabling factor is how do we sustain it? And this is one of the areas that I need to spend some time sharing with you for the last 2 minutes. We believe that the greatest accountability for any health improvement program or any development program is actually not the people who are conducting that program. It is not WAHO. It is not the federal ministry. It is not the ministries of health. It is the consumers. It is the people who are the beneficiaries of that program that can be the greatest accountability guardians of that program. And this is where we really need to work very hard with our community leaders, with our religious leaders, and with the people who are the influencers in our community. We all know about excellent programs that have come out of Nigeria. Some have come out of other countries across West Africa. But we'll find that rather than being continued and scaled up, we have a new government, they change things again. We cannot make progress if we continue to go 1 step forward and 2 steps backwards. We can continue to try and develop a political consensus, which is different, of course, from political will. I am sure you are aware of that, because in political will, the leader decides what they want to do, they have their plans, but in political consensus, it is everybody who has involvement within the political elite, whether in opposition or in government. When they come together, you find that there is progress made. But until we develop that, I am challenging the community beneficiaries of this program to ensure that you don't lose it. Make sure that when people come around to fight for elections, they give you what has saved women's lives in your communities. And finally, for us at WAHO, one of the things we will continue to do is to support best practice wherever we see it. This year, we have, for the first time, tried to develop South-South networks of academic researchers. And we have 4 areas that we want to develop these networks on. We have already started with maternal health, and we have researchers from across about 10 of our 15 countries who are active. We have already met 3 times. Professor Konofua is one of the active people there. The next area that we're also going to develop is in child health. And then the third is in infectious diseases, because of course we are battling COVID at the moment. And the final one is on clinical trials. I encourage everyone who is participating here, whether as an attendee or panelist, to please watch out on WHARC's website so that you can contribute to this. And what will WHARC do? WHARC will support the setting up of the network. WHARC will champion it. WHARC will support the secretariat. WHARC will bring them together, and WHARC will give them endorsements so that when you then, and WHARC will also point them to research grants. We have been successful so far, at least this year and last year, in getting a lot of grants for people that we have supported. But those are individual teams. I want now for us to do that as a group across the 15 countries so that we are stronger in West Africa, just like they are strong in South Africa, in Southern Africa. These are the things that we can get from this type of research work that is happening. And of course, you know that this particular program was also done in Senegal, was also done in about 2 other centers in Nigeria. And also we have plans to expand that as the years go by. I am really sorry that I'm not going to be with you for all the period of this discussion, but it's a fantastic project. It is a great thing that you're doing, and the results speak for themselves. My challenge to you is sustainability. We have so many good plans, so many good policies, so many good initiatives, and what happens? We put them on the shelves and people continue to die. That we must resolve, all of us, that we should not do that with this project. Thank you so much for listening to me. And thank you, Toshin. Great to see you again. Of course, as the focal person of WHARC in Nigeria, if you're there, I'm there. So it doesn't really matter that I'm not there physically with you. Thank you very much. Thank you.
Thank you, Professor Kolo, for this great remark to us today. I've heard from Professor Kolo that it's heartwarming to know that we have researchers and the policymakers all seated together so that we can translate research outcomes into policies that will help our people. And again, from the DG of WHARC, we have heard about the priority areas of the work of WHARC within the region to be, among others, maternal and child health, standards of care, medicine, and vaccines production. And we've heard that they are working assiduously to ensure that they build capacity in the region, strengthening network and sharing best practices, which is currently ongoing that I'm aware of. WHARC finds a way to bring people together to share best practices, you know, like we are doing here. And he has challenged us about sustainability. We have good and laudable programs, but how do we sustain them? He has challenged also the beneficiaries of this kind of programs, the people that we take care of at various levels of governance. He has challenged them to hold our leaders accountable. They shouldn't just be there to vote. They should hold them accountable for good services and public goods like health, as we know. Again, he has asked us to watch out from the website of WHARC for potential grants that might be coming on very soon. For all this and many more today, we want to thank Professor Kolo for the support to the region and for all the good work they've been doing, especially during the COVID-19 era, especially to the Women's Health and Research and Action WHARC Center in Benin City, among other work that they are doing within the region. Thank you, Prof, and we look forward to more from you. Thank you.
Thank you very much. So and in concluding, before I leave, Toshi, can I just finally say, because I know I did mention them, but I haven't really deliberately said that I am extremely grateful to the Honorable Minister of Health of Nigeria, who is also the ECOWAS chair of the Ministerial Coordinating Committee on COVID-19. But also, I'm extremely grateful to the directors and the staff of the Federal Ministry of Health, who are also supporting this program, because as we know, it is bringing researchers and policymakers together, moving evidence into policy. And I know, as I can see from the list, that there are some of our directors there. You guys are doing fantastically, and you know that it's not because I'm saying it here. I've said it to you both privately and publicly. Thank you very much, and wish you a good meeting. Thank you.
Thank you, Prof. So next, I think we can have some video play of the projects and some information from the info. 10 minutes for this.
Hello there. Welcome to Women's Health and Action Research Center, WHARC. Did you know that in the year 2018, WHARC carried out an intervention program called the IMCHA project? By IMCHA, we mean Innovating Maternal and Child Health in Africa. 2 communities benefited from this project. I mean the Okpekpe and Ebele Okpekpe communities of Esakon East Local Government and Ewato 1 and 2 of Esan Southeast Local Government, both in Edo State.
My name is Professor Friday Konofa. I'm the Director of Research and Programs at the Women's Health and National Research Center, University of Nigeria.
How did you select the target communities?
No, we first of all, I think the major criteria was we wanted to base the research in communities that are completely rural. That because we know that in urban communities, for example, in Benin City,
Yes, sir.
ordinarily they should be able to access health facilities because they are available.
That's true.
But by contrast, rural communities in far communities that are remote from the urban centers are the ones that really don't have access to health facilities, and especially the only facilities that they are then constrained to use are the primary health care centers. And we felt that primary health care centers being the entry point to the healthcare delivery system, we felt that if women were at least to be able to access primary centers, then majority of them will receive optimal care. And if there's a problem at that point in time, they can then be referred to secondary care facilities. So our choice of communities was based on the fact that we wanted to locate the project in communities that use only primary care facilities, that have no secondary or tertiary facilities. So we chose this from the northern part of the state, which is Eastern Central, Eastern Southeast, which is very close to the Niger, and is very far from the next secondary care facility, which is located in Iwa, the Matiwa Specialist Hospital. Then we also chose the Isako East, again very far. It's actually the farthest part of the state in the north, again located in the fringe of the Niger. And most of the health facilities there are just primary health care centers, and there are no secondary facilities. And that was the choice. That was the reason we chose the 2 local government areas.
And now this program is coming to an end, but it is very important that before that is done, we go back to the communities for feedback. Come with me. Right now we are getting ready to go to the communities to get the respondents' observation and views about the IMCHA project.
Beautiful faces, no cares in this world, where a girl loves a boy and a boy.
Hello viewers, this is Okpekpe Ward 10. Okay, Mama, we just want to ask you a few questions. Were you around when WHARC came in 2018?
Yes.
You were in this community?
Yes.
Okay. So since that 2018, that's 2 years ago.
That is one.
Okay, see, that's what I think now is one. That's this baby here, so. Okay. So, when you had this baby, did you still give birth to this baby at home or in the health center?
I give birth to her in the health center.
Okay. Before, are you using the health center?
I'm using the health center to carry there and then at home. Yes.
You born at home, you use the health
Like the
center?
first one.
Okay.
When this one program came around, they advise the women, they invite the women, they advise them how to be coming to the health center to come and give birth and to register. Yeah.
Okay.
Then they bring the work. This is also there. So one I forgot, they brought this thing for that time, drugs.
Okay.
They were going to be giving the women.
Okay.
They will register with 2,000 naira.
Okay.
They'll be coming for the antenatal.
Okay.
It's just free of charge until they put to bed.
Okay, these are the things they told the women.
Yes.
Okay.
Then the chairman will come and discharge them. They will not pay anything. They will just carry their baby and go to.
Wow, wow. So, what can you really say? Has this program, has it really affected the attitude of women concerning coming to register here?
Yes, ma'am.
Can you compare it with before they came?
Before, they were not coming. But since the WHARC now brought the program, they were now started coming.
Okay.
Yes, even the young one and the old women, they were coming for registration. We now have more patients.
Wow.
For our antenatal. During our antenatal, everywhere would they feed up. Before, they did not see any of them.
Just before they came, there was an incident.
Okay, sir.
A woman had quadruplets.
That's 4 children.
4 children.
Okay.
Well, the woman almost lost her life, and all the 3 babies, none of them survived.
Ooh, only one survived.
None of them.
None of them.
None of them survived. So at the time WHARC came, this was what motivated the traditional ruler to give the highest support it could to the WHARC program. So when they came and initiated their program, he told them that he was in full support of their program.
So, meaning in brief, in summary, you can say the WHARC IMCHA project was a success.
It was quite a success.
It's a success.
It's a success because if you see right from the time of his session, we have delivered successful delivery of about 200 and.
Okay, sir.
We have been able to deliver 229 women.
Wow.
Very successful.
Wow. We thank God.
In
this community, that's this Opepe and
Ebele. Yes.
These are WHARC field data collectors on duty in Opepe community, trying to get data from women of reproductive age.
Then, when they came, there was a problem in getting a good nurse who would handle this issue in our maternity here. Because of this thing, I think, I don't know what I would call it. Then the government then, political this thing, so they politicize everything. If you don't vote for them, they will not even give you anything. So the people said, no, we must get a good nurse here. They went to Benin by themselves, and they spoke to the Minister of Health and came back to the council. And he made us to understand what they were all after, and the interest now, then we started developing the interest.
And what are the things that WHARC did? What are those things that they taught you women?
Yes, we people from the village, nobody should go.
Okay.
So, hospital more better
than house. Yes. Okay. Now, since that time, I don't need to ask. You already have a baby, I'm sure. How old is the baby?
3 months past.
Oh, congratulations, madam. So, okay, right now, I want to know if your attitude, by attitude I mean the way you women in the community, the way you behave towards going to a center to register pregnancy, to give birth there, has it changed? Has it become better or is it worse than 2018?
It's more better than 2018.
Okay, in what area? Can you explain?
Even some people, even before, many people, like somebody like me, even 2015, I used to born for us before.
Okay.
So people that were, if I'm maybe, that's the time of my delivery, so people will told me, say, stay at home. I will say no. Because if something is wrong, the nurse, the midwife, and everybody, they will know what to do. Because if something happens, nobody will understand.
All right. So since that, before you used to give birth at home?
Yes, it's only one child.
Now?
It's hospital.
Hospital. That's very nice.
Initially, when the program was, when I came into this place, there was no pregnant woman. Until this work of a team started boosting. Everybody would not free discharge, free this. You know, people love. So the team really helped us.
Okay.
So they are all the women in this place. They went to Egohimi. They went to Egohimi, the nearby village. So with this work.
So women have been patronizing the health center very well.
Yes. Than as before.
That's very commendable. Yes, we are back from the communities, and I'm sure you enjoyed the tour. Right now, we can conclude with all assurance and without any iota of doubt that the IMCHA project is a success.
Thank you. Thanks given for that short video clip that we have watched. I have seen as I'm sure we all have seen, the importance of community participation and how important the gatekeepers are. They are critical in creating demands for utilization of PHCs. And we can see one of the things that I've seen is the involvement of the World Development Committee. And we can see how they have been able to get ownership of that program, to the extent that the chairman of WDC was telling us how many deliveries took place. They are involved in the community. They know how many women are pregnant. They know how to help them to get the adequate care needed during antenatal and when those cares are needed during delivery. We thank you for this that you have given to us and this information that you have shown to us today. We move on quickly to the next presentation, which is the description and results of the formative research and intervention activities by Dr. Loretta Intoimo, the senior lecturer from the University of Ekiti.
Thank you, moderator. I'm going to present the description and results of the formative research and intervention activities. I'll briefly explain the study design, intervention activities, and then present the results of the formative and intervention research. The project was a quasi-experiment. We used separate sample pre-test, post-test design. It was conducted in 3 phases. Phase 1 was the baseline. Phase 2 was the design and implementation of intervention. And phase 3 was post-intervention evaluation. In phase 1, we collected formative data from 20 randomly selected communities in 8 wards in the 2 local government areas. Administratively, Nigeria is made up of 36 states, and each state has local government areas, and each local government area is made up of wards. The wards are political and health units, and each ward is made up of several communities and villages. Our study was conducted in 20 communities, 10 from each of the local government areas. We used a multi-method approach to collect formative data in this phase. The methods include a household survey with ever-married women aged 15 to 45, exit interview with women who used PSCs in the communities for antenatal delivery and postnatal care. We also collected data using site assessment of 12 randomly selected PSCs. This was to assess their service readiness, to assess availability and adequacy of physical and medical facilities, personnel, and the cost of services. And then we collected data using key informant interview, 15 of them, with policymakers, community leaders, and PSC health providers. We also collected data using community conversation. We conducted these in 10 key communities in the 2 local government areas. The essence of this was to present maternal health problem to elders. That's what you see going on here. It was to present maternal health problems to elders. We moderated them to discuss it freely, and then they proffered solutions themselves. It was also a very good avenue to enter the communities. And finally, we conducted focus group discussions with different categories of men and women who are in union. 20 of such discussions were held in the 2 local government areas. The results of the formative research indicates that 46.5% of the women use any PSC for delivery care. We also identified some of the barriers to the utilization of primary health care centers in the local government areas. One was difficulty with transportation, particularly in the case of emergency. There was also the problem of poor quality of care, which includes providers' unfriendly attitude. There was also the barrier of lack of drugs and lack of essential facilities, and the problem of high cost of services, particularly affordability here. And then there was also the problem of unavailable providers when they are needed, among other barriers. The results of the formative research informed the design of the intervention activities. All the intervention activities were implemented simultaneously, and they were all implemented through the World Development Committee. The World Development Committee is an initiative of Nigeria's National PSC Development Agency. It is, they operate at the world level to oversee health-related projects in their communities. So we implemented our designs with the World Development Committee in 2 randomly selected wards. And each of the wards has 2 primary health care centers. So our intervention activities were conducted in 4 primary health care centers in the 2 wards. 1 ward in 1 local government area and another ward in the 2nd local government area. The primary outcome indicators of this project include the number of women who use the PSC projects, the 4 PSC projects now for antenatal care, intrapartum care, postnatal care, and childhood immunization. These are the intervention activities. We had the Community Health Fund, Rapid SMS, Drug Revolving Fund, advocacy, staffing, retooling and retraining, memorandum of understanding with transporters, and community health education. I'll briefly explain each of the intervention activities. The memorandum of understanding with commercial transporters was a response to the difficulty in transportation identified at baseline. The WDC chairman in the 2 local government, in the 2 wards where we implemented our interventions, and their members identified reliable commercial transport owners in the communities, and they entered into a memorandum of understanding with them to convey women, pregnant women who are in distress, to the project PSCs. Then we had the Community Health Fund, which the community members themselves called IGOMO and IPAJOMO. IGOMO means money to protect the child. IPAJOMO means financial savings for the child. It was a pool of funds, a kind of community health insurance. Women enrolled into it with a fee of 2,000 naira, which is about $6. And when they enroll, a special IGOMO card, that's what the woman here is holding, is issued to them. In that card, their details are there, the name of the woman, her address, residential address, her telephone number, her husband's telephone number, the telephone number of any other person that is close to her, the telephone number of the WDC chairman in her ward, the telephone number for our rapid SMS, and the key code for our rapid SMS. All of those in that card. And the women who are enrolled in the fund were also entitled to use a transport intervention in the project free of charge. They were also entitled to use the rapid SMS. And during their delivery, they assessed delivery care free of charge. Delivery care cost about 4,500 Naira, which is about $12. The other intervention is the drug revolving fund. This was a response to the lack of drugs that we identified at baseline. The drug revolving fund was set up for the 4 PACs. It was managed by the WDC chairman and the PAC nurses. And Edo State Ministry of Health provided the technical training for them. Then we had the staffing, retooling, and retraining. Throughout the intervention, we made sure that a nurse, midwife, at least one, was in each of our PACs, the 4 PACs. And we engaged one NYC doctor per year. The intervention lasted for 2 years. So each year we had a doctor overseeing the PACs. The other year we also had a doctor. NYC is National Youth Service Corps. It is a compulsory national service by Nigerians who have completed tertiary education. For the doctor, his monthly allowance was partly paid by the local government council and WHARC. And the community provided him very good accommodation. At baseline, we also noticed that when we visited the PACs, we noticed that the facilities there were nothing to write home about. Broken beds, old bed sheets, old mattresses, worn out mattresses, pillows that are no longer pillows. We had to replace all those. And all through in this intervention, we also provided delivery kits all through the intervention period. And then we had a rapid SMS, which we call Text for Life. This is a real-time two-way communication between a pregnant woman who is in distress and the WDC chairman in her ward and the nurse in the PAC. When she's in distress, all she does is trigger a code, and then the WDC chairman receives a text message with her details, and he quickly calls one of the transporters in the MOU to go and pick her. And at the same time, the nurse in the PAC receives a message that there is an emergency with the woman's details, and she begins to prepare to receive her while the transporter brings her. This arm of our intervention received support from West African Health Organization, facilitated by Nigeria's Federal Ministry of Health. And then we had the community health education. This was managed by the WDC chairman and their members. It was a regular health sensitization talk in the communities with input from WHARC. Finally, we had the advocacy. We had an advocacy team led by the principal investigator, Professor Friday Okonofa. He's up here engaging the deputy governor of Edo State on PAC. And then this here, we also see the executive director of WHARC, Dr. Imogan, engaging another stakeholder. Advocacy activities took place all through the life of the project. Now, in phase 3, we assessed the effect of our intervention activities. We used household survey to do that, using a separate sample of ever-married women aged 15 to 45. We used the same questionnaire we used at baseline, and we conducted the survey in 20 randomly selected communities, separate from the first 20 communities at baseline. These are the results now. I'll present results for each of the indicators. Number one indicator is the number of women who use the project PACs for antenatal care. At baseline, we asked women who were currently pregnant whether they had started receiving antenatal care and where. We also asked those who had a recent birth whether they received antenatal care and where. At baseline, currently pregnant women who reported that they used our project PACs, the 4 project PACs for antenatal care, the percentage was 52.6. And then after the intervention, it increased to 76.6, a difference of 24%. For most recent births, at baseline, the percentage who reported using any of our project PACs for antenatal care was 40.8%. After the intervention, it increased to 69.5%, a difference of 28.7%. For delivery care at baseline, 31.8% of the women reported using our project PSCs, and that increased to 59% after our intervention, a difference of 27.2%. Postnatal care for most recent births. At baseline, 41.2% of the women reported using our project PSCs, and that increased to 69.5% after our intervention, a difference of 28.3%. Finally, childhood immunization. At baseline, 59.7% of the respondents used our project PSCs for childhood immunization. And after our intervention, it increased to 78.6%, a difference of 18.9%. And you can see this way, the use of other facilities in the communities for childhood immunization declined from 40% to 21%. Now, to be sure that the increase in percentage we saw over time between baseline and endline in each of the indicators is a result of our intervention activities. We conducted further analysis using regression, a technique that allowed us to control certain factors that may have influenced the increase we observed in percentage. We controlled certain factors such as exposure to the media, where the woman resided, whether she resided in Esako or Esan Southeast. The result shows that the difference we observed between baseline and endline is not only positive for each of the indicators, the difference is strong, the difference is also statistically significant. The likelihood of using any of our project PSCs for antenatal care was 3.87 times higher after our intervention than before the intervention. And the likelihood of using our project PSCs for delivery care became 3.88 times higher after intervention than before the intervention. Postnatal care was 3.69 times higher after intervention than before intervention. And childhood immunization was 2.87 times higher after the intervention than before the intervention. These are publications associated with this project. These are the upcoming publications associated with this same project. We are committed to open data sharing. All the data associated with the baseline results and deposited in an open repository for your attention.
Thank you, Dr. Loretta, for that very succinct presentation. By the way, Dr. Loretta Itomo is a sociologist and demographer and the head of the Department of Sociology and Demography at the University in Ekiti. She's a program associate and a senior researcher and data analyst with the WHARC Center here in Benin City. We thank you so much for this. We have seen what some of the highlights of the program and what advocacy can really help us to achieve in conducting such an intervention program like this, involvement of the community at various levels, you know, and this would further be highlighted with more presentations on this. I thank you for this presentation. Thank you, Dr. Loretta. Going forward, we'll move on to the policy implications and recommendations by Professor Konofua, the lead researcher.
Thank you, Dr. Toshin Jolakwe, for your great moderation activity. Is he hearing me? Are you hearing me? Thank you, Dr. Loretta, for that great presentation. I think the presentation actually very succinct
and very elaborate in describing what we did in the two local government areas, trying to promote the use of skilled pregnancy care by the rural women that we investigated. So this was actually a quasi-experimental design, try to see what we needed to do to ensure that women, instead of going to traditional birth attendants, use skilled birth attendants. As you know, one of the recommendations of the WHO, World Health Organization, about how to reduce maternal mortality in many countries is the use of skilled birth attendants. In Finland and Sweden, which have the lowest maternal mortality rate in the world, the skilled birth attendant rates are around the region of between 98 to 900%. In Nigeria, to date, the demographic and health survey indicate that only about 34% of women use skilled birth attendants for delivery, whereas a large proportion of women tend to use traditional birth attendants. We believe very strongly in WHARC that women's continued use of traditional birth attendants, especially those in rural communities, would prevent this country from achieving the Sustainable Development Goal, as it did in preventing us from achieving the Millennium Development Goals. So going forward, are you hearing me? Are you hearing me? Yeah. So going forward, we will work very hard as a contribution that we intend to make to ensure that women in, like I say, hard to reach marginalized communities are able to enter the healthcare system when they are pregnant and to be able to deliver safely. Now, I'm going to talk about the policy implications. Why was this project successful? We are indeed very excited because when we went to the community, we knew nothing. And I think that the basic reason, and I think that one of the reasons that we succeeded, is first because we first asked questions. We asked the community questions why they were not using. We didn't go there with ideas. We designed our intervention based on what the community members talked to us about, their challenges, the barriers to their use of primary care for maternity care. That was it, because we didn't come from outside trying to tell them this is what they must do. Rather than do that, we asked them the questions as to why, and then they gave us specific answers as to why they did not use our facilities. And then secondly, we then engaged them to provide the solutions. How can we address? And remember, we talked to women, we talked to men, we talked to traditional leaders, and they talked about what they can do. And based on that, we asked them to identify people who work in the World Development Committee, has been described by Dr. Loretta. We didn't select those members ourselves. We waited for the community chief and king, who's here today, and his council members to identify those members. We didn't force members on them. We asked them to select those they can work with, those they trusted, and those were the ones who eventually worked on this program. And I think those are the two reasons. First, because we tried to address some of the concerns that the communities had. And secondly, we allowed the community to choose those that will help to work on the project. And thirdly, most importantly, all of the interventions that we had of the facilitators, we call us enzymatic facilitators. We just provided the enabling environment, the support and all that. But every single activity, be it health education, be it the community funds, be it the drug recovery fund, they were all led. And today, if you go to those communities and simply go and talk to the chairman of the World Development Committee, he will give you data where all these things are located, including the project funds, which will open in communities. They led them, they open the account, they are signatory, and they are the ones that disburse the funds. So I think those are the things that led to the success of this program. Next slide. So just to summarize, the project put on, yes, was successful because We did a needs assessment, as I've described. We engaged community stakeholders throughout the project life cycle, phase 1, phase 2, and even the project evaluation. They did the evaluation themselves, and the community leadership owned the project right from the very beginning. This is very important because when the funding ends, they are expected to continue, and they promise that they will continue, as we can hear later on. And then most importantly, we also work with government stakeholders, the National Primary Care Development Agency and the Edo State Primary Care Development Agency. They work with us from time to time. We have several meetings. So what are the policy implications? The first is that, we are talking about, Nigeria has about 30,000 primary centers. Only about, they say about 40% of those PSCs are functional. In Edo State, we have 505 primary centers. And again, only about 40 to 50% of them are functional. So the first step is that, look, primary center is, we've talked about primary care being the entry point. Governments must make it a priority to improve primary health facilities, especially in rural communities, because there's no other form of healthcare that those people can attend to. If you don't provide and improve primary health facilities, you are telling them to go to traditional healers who don't have the experience and skills to manage that. And these facilities must be well staffed and well equipped for impact. And when I mean by staffing, adequate nurses and midwives, and if possible, what I'll call a medical doctor, so to say, who will help to supervise nurses. Primary centers don't necessarily need doctors, but we need doctors to play advisory roles because the normal deliveries which PSCs are supposed to take can be done by nurses and midwives. And indeed, let me also say, for the purpose of everybody in this webinar, that to date, it is known that 95% of pregnancies are normal, meaning that between 19 and 95% of deliveries take place normally, normal vaginal delivery. It's only in about less than 5 cases that you talk about difficult deliveries for which you require secondary care. So most of these deliveries can be taken in primary centers because they're normal deliveries. And in fact, when we work in tertiary hospitals, university tertiary hospitals, teaching hospitals, most of the normal deliveries are taken by nurses and midwives. And it's only when they become complicated that you invite the obstetrician and gynecology. So what I'm saying is that we should adequately provide good primary care facilities and staff them so that about 90% of women who deliver can deliver in primary care facilities. And then health workers and community liaison are very important. Let me also say it is not just important to put PSC. For these PSCs to function optimally, we need to ensure that the health workers who may be foreign, who may come from outside to work in those rural communities, are linked to the community liaison. They are working with the community leaders and they can be very effective. Community leaders will enable them, working with them will enable them to ensure that the PSCs are used and that women and men know about the PSCs and that they are using them. Next slide. Also, we know about the women in this program. We use what we call World Development Committees created for these projects. The World Development Committee, as has been explained by Dr. Loretta, is the federal government established this several years ago as a way of coordinating the projects in rural communities. But in 2018, after we started our program, the federal government changed this into what we call CHIPS, which is Community Health Influencers, Promoters and Services Program. It was introduced into the country by the National Health Primary Care Development Agency in 2018 and is currently being implemented. I think the results of this study show quite clearly that CHIPS, if that means finding ways to engage community to be part of the primary care primary care management team in the rural community, is highly effective. But it's important for us to engage them meaningfully to ensure that the communities own the projects. And I can tell you, rural communities are very committed to anything that has to do with health. They are committed to management of their communities. They also have their own management structure, which means that if anything happens in that village or in the community, everybody knows and everybody is concerned. And if today, when we talked about raising funds, most of the funds that were raised for this project came from the community members. I can remember very well that the accommodation provided for the National Youth Corps Doctor was built from very beginning by the king of Okpekpe. And they also provided the funding for the drug revolving funds, which we started. So it's just for us to tell them what the problem is, and if it will improve the health of their people, it will surely happen. So chiefs will work only if the communities are properly engaged. And you should work and find out what each community needs. Don't go there and give them an agenda, because each community is different. Do a needs assessment, find out what they need, and then engage the community to find solution to those problems. Next slide. This is the last recommendation I would like to make, is cost remediation. This is very important. As before we started the intervention, women pointed out high cost of services in PSCs as a barrier to the use of the PSCs. Even when we finished and we reduced the costs for several women to something that we thought was very manageable, they still complained of high cost. The reason why those, they still complain of high cost. Those who used the facility and those who did not use still complain of high cost. I want to say that in a region, Nigeria currently has one of the highest rates of poverty in the world. And you can see when you have a high rate of poverty, especially in rural communities, it is unfair to ask them to begin to make out-of-pocket payment for their health care. No, we know that Nigeria today, 70% of our health care is out of pocket. It will be wrong, because if a woman pays 2,000 naira for delivery or 4,000 naira for delivery, that's almost a lot of money coming from out of pocket, which they are not prepared to spend. So our recommendation, because the truth is that, as I mentioned earlier on, PSCs take care of normal deliveries, and only when the deliveries are abnormal, that we refer them to secondary healthcare facilities. So our major recommendation is that governments must consider removing costs for PSC, for women who use PSCs in the country, especially in rural communities. Because we've calculated, there's another paper we're writing now looking at the cost effectiveness of PSCs use in rural communities versus non-use of PSCs. And we're convinced that removal of cost for use of PSCs for maternity care will be very effective and will not diminish what the government or anybody else is doing, will not be too costly for government to afford. And the basic primary care development agency fund that the government is currently putting in place, we believe very strongly that this is achievable. Now, how do we recover the cost? For example, people who ask the question, if you say, should be free, I think the most important thing is the secondary care facilities, that everybody uses primary health care. We were surprised to find out from a study that, the rich women and those who are highly educated tended not to use primary health care in rural communities. They believed that primary health care was an inferior form of care to be used only by poor women, and those more educated women we interviewed prefer to use maybe secondary health care and primary health care. So I think one of our recommendations is that we should eliminate costs for primary health care services, especially in rural communities. Any person, any woman who therefore wants to use secondary or tertiary health care facilities when she ought to be using primary health care should be charged double the cost that she would have paid in primary health care facilities. This will discourage women from going to secondary health care facilities rather than using primary health care facilities. And it is one way to recover the cost of elevating costs for those who use primary health care facilities. So ladies and gentlemen, this is a very important project, and we look forward to people testing it out. We look forward to scaling it to other parts of Edo State and in fact to other parts of Nigeria and to West African region. We believe very strongly that communities should be very more strongly engaged in primary care disbursement. The government must put money as a public enterprise to improve primary care facilities, and that indeed women, especially in poor communities, should not be made to pay any cost for the use of these services. I thank you very much, and I look forward to comments on this presentation. Thank you.
Thank you, Professor Konofua, for this very interesting presentation. Professor Konofwa is the lead investigator in this research. He's our teacher, and most of us would have read some of his books as medical students, and even trying to add more to knowledge in the course of our development. So thank you so much for this. Among other things, he said today that CHIPS, one of the policies of the National Primary Healthcare Development Agency, will work if communities are properly engaged. If we learn to engage the communities, meet with the gatekeepers, they would know where the shoe pinches and where interventions are needed, and interventions will be more effective at the community level. Moving on, I don't know if we have a representative of the Federal Ministry of Health, the Commissioner for Health in those states, or the State Primary Healthcare Development Agency here. While we wait for them, like I mentioned in my introduction earlier today, that we have one of the proponents of maternal and child health intervention in our midst, Dr. Olusegun Mimiko, is a champion of the ABIA program in Ondo State, which has been known to be effective in reducing maternal and child health. If you will be able to talk to us about this specific intervention in Ondo State and how costs of service were able to be reduced for women, and for easier access for healthcare delivery. Dr. Olusegun Mimiko, Your Excellency, sir, please, if you are here, let's hear from you. Thank you.
Hello, can you hear me? Hello? Hello, can you hear me? Hello?
Yes, we can hear you.
We can't hear you, Dr. Mimiko.
Hello, can you hear me?
We can hear you now.
You can hear me now. Yes, I was saying that. Can you hear me? Yes, I was congratulating you and those who have funded this research, and especially Professor Konofwa for his energy and enthusiasm and resourcefulness in tackling maternal mortality used in Nigeria and in Africa. And I was going to say that the results, the outcome of this year research has confirmed what we had always known and what we knew in Ondo State from our own experience. Number one, that most people in the rural areas that do not patronize primary healthcare facility has been due to attitude, financial barrier, lack of drugs, providers, and all of that. And we have also found out that primary health care must be taken as the responsibility of government. And what I mean, the funding of primary health care should be the responsibility of government. I am not discounting the fact that community has a role to play. And like you pointed out in your research, the CHIPS, or the community vanguard, like we call them, or community rangers, have a great role to play. The first intervention with the community, there must be proper need assessment so that the intervention must align with the need of the community. Now, having said all of that, let me also say that financial barrier is a very critical issue when you talk of primary healthcare service uptake. Once you can remove financial barrier and you improve on the quality of the resource, the staffing, make available drugs and medicaments, I can assure you that from my experience, the rural community will patronize the primary healthcare facilities. And let me just say this, that our experience also showed us, because we had free services at primary, secondary, and tertiary level. And we just found out that year in, year out, the cost of care kept going down because people did not have to wait until complications set in before they interface with health facilities. In our first year, our cost of care was around 12,000 naira per patient. By the third year, it has reduced to just about 5,000 per patient because we were seeing less complications and we were getting the type of outcome that we desired. And the issue of cost is absolutely important. Let me just talk about advocacy. Advocacy is very important. The WHARC Director talked about political consensus. Well, let me start by saying that the issue of our dysfunctional health system is not only a technical issue, it must be taken as a political issue. Once you can generate the necessary political will, easy to, hello? Hello? Hello?
Hear you. We can hear you, Prof.
Okay, I was talking of the importance of political will, that we must, while we tackle the technical aspect of all of these issues, we must pay a lot of attention on political advocacy. Because when you have political will at the highest level, it becomes very, very practicable to make the necessary investment in primary healthcare. And once the beneficiaries actually start enjoying these services, they will be the most important sustainability factor in whatever you put on ground. Once again, I want to congratulate you, and I think this result has been an eye-opener that the demand side and the supply side, the content supply side, traditional birth attendant, we actually incentivize them out of the trade. We incentivize them, ask them to refer patients to primary healthcare facilities to which they were assigned. And within 22 months, in Ondo State, we have 14,800 referrals from traditional birth attendants because we incentivize them with money. For each referral, they get a coupon. And at the end of the day, it was a win-win situation for everybody. Once again, I want to congratulate you for this very wonderful research.
Thank you so much, Dr. Olusegun Mimiko, His Excellency, the former governor of Ondo State, and we're grateful for the good work you did during your tenure. Thank you so much, sir. You mentioned that financial barrier is a major barrier to access to care at the community level, and political will is one of the things that we need to do to mitigate against this. For further reading on some of this, on the work of WHARC, there's a link being shared now that we can get more details for this one. We recognize the presence of Dr. Memuna Nana from MPACDA. We will wait for your comment further, in the course of this presentation. While we wait for you, I want to recognize the community voices represented by the Onojes of Okpekpe and Ewato, the king of these two communities where this work are done, His Royal Majesty. They are here with us today, this afternoon, and we'll be able to hear directly from them. The King of Okpekpe, please. Thank you, sir. No, not it. The King of Okpekpe. Okay, so while we wait for him, can we have the representative of the National Primary Care Development Agency? Oh, sorry. I understand the King of Okpekpe is coming. The King of Okpekpe.
The chair is just speaking. Okay.
It looks as if we are having some sound problem here.
I'd like to congratulate the Professor Kunofwa, for what he has done for my community. We enjoyed it. It was very successful in Okpekpe, and it is our prayer that the government should take over from there. And it is also a prayer that all the wards in those states should experience what we experienced. That is to say, they should also try it and see that the women will no longer live at home, and that the women will want to go to the maternity. They want it, but it is the affordability that has disturbed them all along. So we want continuity, and I want to say that it is accessible and was very cheap because the community head was prepared to help them, and we actually helped in making this research a success. Thank you once again. And His Royal Highness Peter Abalune Osigbe, the Onwe of Okpekpe.
Thank you, sir, for your contribution, for all the things the community did to ensure the success of this project. And I understand you supported them so well, even including your personal resources to ensure that women in your community enjoy better services. Thank you. God bless you, sir. Can we hear from the King of Ewato? if he's around, or his representative if he's there with us. Okay, I understand he's not present with us. Is Dr. Maimuna Nana still around?
Yes, hello.
To add, if the moderator can permit me to say that the reason that the king of Ewato is not here today is because the chairman of the World Development Committee about 2 weeks ago, unfortunately, died. He had a heart attack and died. There's somebody who was so good, who supervised the project in Ewato, who led the project. And before then, a week before then, we had a meeting in WHARC, during which we made a presentation to the Canadian community. And soon after he left the meeting, without knowing that he was sick, he passed on. So I want to take this opportunity to really say that we are indeed very sorry to hear of the passing of the WHC chairman of Ewato, who was a major contributor to the success of this program. And they commiserate with the Onoji of Ewato on this very unfortunate death. In fact, I spoke to the king of Ewato yesterday, and he said that this particular chief was one of the preeminent, one of the most preeminent, one of the most helpful, one of the most community-oriented chiefs in his kingdom. And tomorrow will be the burial ceremony, and WHARC will be represented there, and so on and so forth. So I want to report that this fortunate that took place, and that's the reason why the king of Ewato is not able to join us today. May his gentle soul rest in perfect peace.
Thank you, Professor Konofa, for the updates. Again, we have Dr. Maimuna representing the National Primary Healthcare Development Agency, who will talk to us about the policy implication for the MPHCD. And if we have more comments on the CHIPS program, we can have it at this time. Thank you, Dr. Maimuna.
Hello, good afternoon. Thank you very much for having us. And okay. Sorry, my network is a bit unstable. So my network is a bit unstable. That's why I'm not using my video. Hello?
We can hear you.
Oh, okay, great.
Please just go ahead. We can hear you.
Okay, thank you. So on behalf of my executive director, want to appreciate the researchers on this very important piece of work. As has been highlighted, it's very important that the primary healthcare works, because that's what is accessible to the rural population, and a large percentage of people should be accessing care from that level. I appreciate the comment made about engaging the community effectively. Yes, that is very important. And it would be interesting to learn what other ways this was achieved. Effective engagement, that is outside of the engaging the WDCs. How was community involvement ensured to see that people take ownership of this program, because that ownership is also tied to sustainability. And I recall that Dr. Kolo in his remarks spoke about sustainability, because a lot of programs have been implemented in the past, a lot of pilot-like programs. So what we at MPHCD we're looking to do is how to move from that pilot, take ownership, and look at what has been happening both nationally and around the world with regards to community health programming, and we took a lot of lessons learned and developed the CHIP strategy, that's the community health influencers, promoters, and services. This is aimed at strengthening the community component of primary health care, and it has as its overall goal contributing to reduction in maternal and child health morbidity and mortality. Of course, there are a lot of things that are involved in achieving this, right from governance and leadership to the coordination at the different levels of government. Then at the community level, we need to ensure that the structure is such that from the planning, the community is engaged. So we really welcome looking at the findings from this research to see how the communities were involved from the planning stage and to the implementation and dissemination of the results of these programs. Because as we go to implement the CHIPS program, what we do is look at what exists within that community and see what we can transition or harmonize so that we do not have vertical programs running at the community level. So we will welcome other questions. But outside of the community, that's the demand side component which the CHIPS is addressing, we'll also be interested in looking at what happened with regards to the supply of the supply side, that's the engagement of the skilled birth attendants itself. I saw a question on the chat about some of the aspects of this, and we'll be really interested in the response. Thank you.
Thank you, Dr. Memunat, for the comments and the information shared with us already. So we have a few questions coming in through the chat box. We'll be able to take a few and give responses to them now. So I have the first question coming from Elizabeth Malik-Wichi. I'm asking that the 58,000 maternal deaths that is happening in Nigeria is huge. No one can deny that. Even one maternal mortality is still a concern. The question is on the objective, the overall objective of this, to contribute to the reduction of this maternal mortality. The objective, the broad objective of this particular intervention project to contribute to the reduction of maternal mortality. Let me take a few questions so that we can have responses to them together, as we are pressed for time at this time. No. Another question is asking about the sustainability. How are we able to address sustainability on this intervention project? That's the second question. Okay, so we can have answers to those two and take other questions from there, please. Thank you.
Thank you very much. On the question of sustainability, are you hearing me? I think our design was ab initio designed to ensure sustainability, the involvement of the community in the design and the project implementation at every phase ensures that, first of all, the community members now are knowledgeable about the problems, about the issues, and even without funding, they are determined to ensure that this project is carried out because they are now more knowledgeable. Part of what reason that in the past we have not been able to sustain some of these interventions is that intervention comes from outside and they are dumped on communities. And when the funding goes, the funding also goes with intervention. But right from the very beginning, we engage the community members, and we actually have a commitment from down and the Royal Majesty is still there. We can confirm that most of the funds that we use for various aspects of this project came from the community, and they have committed themselves to continuing the intervention even after the project ends. So that is part of it. And secondly, we've done a lot of advocacy, created awareness amongst the local government staff who run the PSCs. For example, the issue of cost in the past was because the primary centers were asked to make some money every month, the money they make from PSCs back to the local government councils. We have been able to do advocacy programs. We have been able to convince the local government policymakers that this is not necessary. It is not necessary for the LGAs to demand that PSCs return some money to them from what they make in service provision. And then, in fact, one of the things I've not said is that even the PSCs themselves are started making more contribution to the growth and development of the PSC. We have created awareness and we have built capacity and knowledge about the importance of PSC for normal delivery and so on and so forth. So we believe that the program can be sustained beyond that, beyond this period.
I think we'll be able to accommodate one or two questions more. Another question came that, okay, one of the presenters mentioned that funding of PSC should be the exclusive duties of the government. That if community contribution worked in this particular project, why do we need government funding? I hope we'll be able to get a response to that, sir.
No, not the response. The response is that what we wanted to prove is that if we reduce costs, then if we reduce costs, then women will use the services. And therefore, this issue of asking community to pay is not sustainable. It's not something that all communities can do. Some communities can do it, but certainly not all communities. So we cannot be saying that because communities have paid, therefore they should continue paying. No. The government of Ondo State, under government, President Dr. Olusegun, paid for PSC services and made services free. And a lot of women used those services. So universal health coverage, which means that everybody must have equitable access to health care, is what is now being advocated around the world. Today, Nigeria has some of the worst indicators for universal health coverage. Even in African countries, Nigeria is one country where universal health coverage is not doing very well. And we're asking our governments to make more contribution to public health funding, including funding of primary health care, so that the burden will be taken away from the communities, it will be taken away from donor agencies. It will be something that government can speak about as their contribution to development over time. So government must take this up as a responsibility, as the responsibility of government to ensure that primary care services, especially maternal and child care services, are free, especially in rural communities.
I think we have the last question from Peter Chikana, asking, what is the staff complement of the PSC facility? Do staff in these facilities perform assisted vaginal deliveries? How functional is the referral system? Is the workload sufficient to ensure health workers keep their skills?
Thank you. That's a very heavy-loaded question. The first to say is that primary health care centers are not supposed to take assisted delivery, assisted by forceps, unless, of course, well, in areas where secondary care facilities are far away, they are supposed to take normal delivery, to deliver the placenta, to admit osteosis, and also if they had a manual removal of the placenta, they can also perform that. But any other complicated delivery, such as prolonged labor, they are supposed to make an early diagnosis of prolonged labor, to make an early diagnosis of hypertension in pregnancy, and so on and so forth, and do early referral to secondary healthcare facilities. One of the major interventions we included here was improvement of referral services. We had a liaison with secondary healthcare facilities around the two local government areas, as well as private facilities that can provide secondary care. And we ensured it was the same community, world development committees, that ensured that whenever a woman was in difficult labor, with the same vehicles that we have put aside, we have registered to work with us on this program, the World Development Committee members will ensure that these taxis or these vehicles that we've set aside to help us, the same vehicles will be asked to take the woman to the secondary care facility for things like cesarean section and so on and so forth. And we had a couple of that in this program. So part of what we included was referral system. And again, this is one area we can show the model, and it's possible for government to adopt this model because right now, referral from primary and to secondary care facilities is not very good in the country. And that's one reason that people go to secondary care facilities.
Thank you. So, permit me to ask a very, very, very last question. Any plan for scale up?
Well, we are hoping that we will be able to scale up. Not only, we already begun the process of scaling up in Edo State. So we are having a dissemination seminar. We've had a face-to-face dissemination seminar where the Commissioner for Education, Commissioner for Health was present, and we're already working on plans to scale up this particular intervention. Edo State government has made primary care as one of its foundational activities in this second tenure of our governor. And we are going to work with the government to ensure that all of the recommendations made through the use of the TIPS. The TIPS is working very well through the Edo State Primary Care Development Agency. We ensure that the communities are properly engaged in the implementation of TIPS using the model that we've identified through this project, and also ensure that the government pays for these services rather than waiting for women to pay for services. Again, a policy seminar workshop a couple of days, and then ensuring that one of the outcomes will be that the government adopts this. And if this happens, we are sure that we'll be able to scale it up to other states across the country.
Thank you, Prof, for the answers provided to us. I'm afraid that will be all for the question and answer time. We might be able to interact on other platforms. We are careful not to exceed so much from the allotted time. We want to take the last presentation for the day, the collaborative role of the University of Ottawa by Professor Sani Yaya. That will be our last presentation, 3 minutes maximum. Professor Sani Yaya, if you're there, we want to listen. Thank you.
Health Organization. Thank you.
Sani Yaya from the. Hi everyone, I'm Sani Yaya from the University of Ottawa, and I'm the Canadian PI on this collaborative project on how to optimize primary care for skilled maternal health care in rural Nigeria. As you know, one of the goals of this research program is to really assist sub-Saharan African countries in resolving pressing health system challenges to improve maternal, newborn, and child health. I'm glad to be here today with you to share some thoughts on the knowledge that we've gained from the experience of implementing this project. So let's get it started. So first of all, I think it is important for the audience to better understand the context of this partnership. As you know, foreign domination in setting research priorities and project management may have negative impact, which outweigh most of the time the apparent benefit of research finding. That is why in this project, we've tried to involve national academic leaders and the institution in this project so that research can be translated into policy. So the approach that we've taken is a unique one. So this research partnership was thought as a research with, I would say, rather than research on. So implementation team our implementation team has been working with communities, teams, practitioners, and also policymakers rather than researching on them. And I think this is really extremely important. This also reflects, I will say, the need to move away from traditional understanding of research informing practice to an interdependent nature of research and practice informing each other's. And that is what we've tried to do over the past 4, I would say 5 years. So obviously, it is important, I believe, to build an environment that enables alignment of voices of all stakeholders, researchers, practitioners, and policymakers who have shared interests, and so that we can build mutual benefit from this collaboration. That being said, I believe that there are some key challenges that need to be considered. The first one is the fact that collaborative research is complex, and we have been able to experience this over the past few months. It is complex because the type of research that we have been doing also deals with complex interstructural system, I believe. There is also a need to take into consideration things such as shared beliefs, common goals, and also to keep in mind one aspect, I believe, that has to do with equity among research collaborators. And finally, the need for the team members to show and demonstrate some flexibility. Lastly, one thing that I will share with you, so will allow me to outline, based on my experience on this project, some of the things that I believe could facilitate the preparation of this type of research collaboration, but also I would like to speak to the research collaboration itself, so the process, and also I will say the long-term benefit of this type of partnerships. So at the preparation level, one thing to keep in mind is really the importance to allow or to acknowledge, I will say, key enablers on the need and relevance for this collaboration. And you will see that the model that I'm presenting here reflects my experience on this project, but it also it borrows from a paper that was published, I believe, in 2008 by Nystro and colleagues. So at the process level, one thing that is really important, I believe, is to make sure that the relationship that are established are very helpful, and if not possible, there should be time to establish common trust and working relationships to ensure that goals are very well aligned, and that the team is able also to recruit and hire skilled researchers and to rebalance power relationships. The long-term impact at that level, I believe, one thing that is crucial to keep in mind is that these enablers or facilitators will really increase the chance of the collaboration partnership and also help uptake of research. So I don't have a lot of time. I only have 1 minute, but these are some important thoughts that I would like to share with you. And that is really, that derives, I will say, from the experience that I gathered throughout the implementation of this research in Nigeria. So thank you very much.
Thank you, Professor Sonny Yaya, for that presentation. And we can see from that presentation, we cannot overemphasize the importance of collaboration at all levels between the researchers, the academics, and the funders. Even at the community, we need to continue to collaborate to ensure that we have a successful intervention like this. Ladies and gentlemen, you will agree with me that we've really had a good time of a lot of information about this project. The policy briefs are there, the links for the policy brief are shared, and the research papers, all the papers available on this research are shared already by Mr. Abraham, our ICT person. On behalf of the Women's Health and Action Research Center in Benin City, the University of Ottawa in Canada, the IMCHA initiative, and the West Africa Health Organization, I want to sincerely thank you for the time you have invested to listen to this report. And we know that we'll be able to pick one or two lessons so that we can use, if we need to scale up, if we need to replicate this kind of initiative in other places, they are available, and the WHARC Center, we are open for more dialogue, more information sharing, and other meetings on other platforms as regards this. We want to sincerely thank you for investing your time to listen to this report. And I want to thank you most sincerely and wish you a pleasant evening. Thank you all for listening to us. Thank you. While we continue to play some of the clips from this research, we have come to the end of this webinar. I thank you most sincerely for listening to us. Thank you.
WHARC. Did you know that in the year 2018, WHARC carried out an intervention program called the IMCHA project? By IMCHA, we mean Innovating Maternal and Child Health in Africa. 2 communities benefited from this project. I mean the Okpekpe and Ebele Okpekpe communities of Esakon East Local Government and Ewato 1 and 2 of Esan Southeast Local Government, both in Edo State.
My name is Professor Friday Konofwa. I'm the Director of Research and Programs at the Women's Health and National Research Center, Benin City, Nigeria.
How did you select the target communities?
No, we first of all, I think the major criteria was we wanted to base the research in communities that are completely rural. That because we know that in urban communities, for example, in Benin City,
yes, sir.
Ordinarily they should be able to access their facilities because they are available.
That's true.
But by contrast, rural communities in far communities that are remote from the urban centers are the ones that really don't have access to health facilities, and especially the only facilities that they are then constrained to use are the primary care centers. And we felt that primary care centers being the entry point to the healthcare delivery system, we felt that if women were at least to be able to access primary centers, then majority of them will receive optimal care. And if there's a problem at that point in time, they can then be referred to secondary care facilities. So our choice of communities was based on the fact that we wanted to locate the project in communities that use only primary care facilities, that have no secondary or tertiary facilities. So we chose this from the northern part of Edo State, which is Esan Central, Esan Southeast, which is very close to the Wananja, and is very far from the next secondary care facility, which is located in Iwa, the Matiwa Specialist Hospital. Then we also chose the Isako East, again very far. It's actually the farthest part of the state in the north. Again, located on the fringe of the Wananja. and most of the health facilities there are just primary health centers, and there are no secondary facilities. And that was the choice. That was the reason we chose the two local government areas.
And now this program is coming to an end, but it is very important that before that is done, we go back to the communities for feedback. Come with me. Right now we are getting ready to go to the communities to get the respondents' observation and views about the IMCHA project.
Beautiful faces, no cares in this world, where a girl loves a boy and a boy.
Hello viewers, this is Okwekwe Ward 10. Okay, Mama, we just want to ask you a few questions. Were you around when WHARC came in 2018?
Yes.
You were in this community?
Yes.
Okay. So since that 2018, that's 2 years ago.
That is one.
Okay, see that 2018 and now is one. That's this baby here. So okay. So when you had this baby, did you still give birth to this baby at home or in the health center?
I give birth to her in the health center.
Okay. Before are you using the health center?
I'm using the health center to parent there and then at home.
Yes. You born at home, you use health center.
The first one. Okay. When this WHARC program came around, they advised the women, they divide the women, they advised them how to be coming to the health center to come and give birth and to register. Yeah. Okay. Then they bring the WHARC. This is also there. So one I forgot, they brought this for that time drugs.
Okay.
That we were going to be giving the women. Okay. They will register with 2,000 naira. Okay. They will be coming for the antenatal.
Okay.
It's just free of charge until they put to bed.
Okay, these are the things they told the women.
Yes.
Okay.
The chairman will come and discharge them. They will not pay anything. They will just carry their baby and go home.
Wow, wow. So what can you really say? Has this program, has it really affected the attitude of women concerning coming to register here?
Yes, ma'am.
Can you compare it with before they came?
Before, they were not coming. But since the WHARC now brought the program, they were now started coming.
Okay.
Yes, even the young one and the old women, they were coming for registration. We now have more patients.
Wow.
For our antenatal. During our antenatal, everywhere would they feed up before. They not see any of them.
Just before they came, there was an incident.
Okay, sir.
A woman had
quadruplets. That's 4 children.
4 children.
Okay.
Well, the woman almost lost her life, and all the 3 babies, none of them survived.
Ooh, only one survived.
None of them.
None of them.
None of them survived. So at the time WHARC came, this was what motivated the traditional ruler to give the highest support it could to the WHARC program. So when they came and initiated their program, he told them that he was in full support of their program.
So, meaning in brief, in summary, you can say the WHARC IMCHA project was a success.
It was quite a success.
It's a success.
It's a success because if you see right from the time of his session, we have delivered successful delivery of about 200 and
okay, sir.
We will be able to deliver 229 women.
Wow.
Very successful.
Wow. We thank God.
We
in this community, that's this Okwepe and Ebele.
Yes.
These are WHARC field data collectors on duty in Okwepe community, trying to get data from women of reproductive age.
Then, when they came, there was a problem in getting the good loans who will handle this issue in this in our maternity here. Because of this thing, I think, I don't know what I would call it. Then the government then, you know, political this thing, so they politicize everything if you don't vote for them, they will not even give you anything. So these people said, no, we must get a good nurse here. They went to Benin by themselves, and they spoke to the Minister of Health and all. Came back to the council, and he made us to understand what they were all after, and the interest now. Then we started developing the interest.
And what are the things that WHARC did? What are those things that they taught you women?
Yes, we people from the village, nobody should go.
Okay.
So, hospital more better
than house. Okay. Now, since that time, I don't need to ask. You already have a baby, I'm sure. How old is the baby?
3 months.
Oh, congratulations, madam. So, okay, right now, I want to know if your attitude, by attitude I mean the way you women in the community, the way you behave towards going to a center to register pregnancy, to give birth there, has it changed? Has it become better, or is it worse than 2018?
It's more better than 2018.
Okay, in what area? Can you explain?
Maybe some people, even before, many people, like somebody like me, even 2015, I used to born for us before.
Okay.
So people that were, if I'm maybe, that's the time of my delivery, so people will told me, say, stay at home. I will say no, because if something is wrong, the nurse, the midwife, and everybody, they will know what to do. Because if something happen, nobody will understand.
All right. So since that, before you used to give birth at home?
Yes, it's only one child.
Now?
It's hospital.
Hospital, that's very nice.
Initially, when the program was, when I came into this place, there was no pregnant woman. Until this work of it started boosting. Everybody would not free discharge, free this. You know, people love. So the thing really helped us.
Okay.
So they are all the women in this place. They went to Ebohimi. They went to Ebohimi, the nearby village. So with this work.
So women have been patronizing the center very well.
Yes. Than as before.
That's very commendable. Yes, we are back from the communities, and I'm sure you enjoyed the tour. Right now, we can conclude with all assurance and without any iota of doubt that the IMCHA project is a success.